Welcome back to the Deep Dive. Today, we're shifting gears a little. We are moving away from general medical curiosities and stepping directly into the line of fire. If you're listening to this, chances are you aren't just looking for some cocktail party trivia about lungs.
No, not today.
You're likely an anesthesia resident, maybe staring down the barrel of the Gujarat University MD Anesthesiology exams or the DNB final theory. And you need to know this topic cold.
That is absolutely right. Today isn't about casual learning. It's about survival.
Survival, I like that.
It is. It's about walking into that exam hall, facing a senior MD faculty member who's been managing airways for 30 years, and knowing exactly what to say when they hand you a bronchoscope and ask, how do you keep this patient alive?
The stakes are definitely high.
Yeah.
So here's a premise for today's deep dive. We're treating this strictly as a simulated Viva and theory prep session.
Exactly.
I'm going to play the role of the inquisitive, slightly stressed resident. Let's just call me the learner. I've read the books, I've skimmed through Miller and Morgan, I've looked at Kaushik Jathanath's notes, but I really need to synthesize it all into something coherent.
And I'll play the role of the examiner, or maybe your senior mentor. My job is to strip away all the fluff. We're going to take that whole stack of sources, your standard texts, the review notes, question bank patterns, and convert them into high-yield, pass-grade answers.
Okay, so our mission statement for today is simple. Convert these complex airway procedures, specifically bronchoscopy and endobronchial ultrasound, or EBUS, into structured answers that are going to score marks.
That's the goal.
And we're focusing heavily on this shared airway concept, because that really seems to be the pivot point for everything in this topic.
It is the absolute core. Look, if you understand the shared airway, you pass. If you don't respect it, you fail. And that's true in the exam and, more importantly, in the operating room.
Right. Let's do it.
Let's get started. Part A, Introduction and Exam Framing.
Okay, Section 1. I'm sitting in the exam. I get a short note or a Viva question. I have to start with definitions. I can't just say, looking into the lungs.
Yeah, don't do that.
How do we define bronchoscopy in a way that sounds professional?
Precision is key. So bronchoscopy is defined as the visualization of the tracheobronchial tree. Simple as that.
Okay.
But to show you really know your stuff, you have to immediately follow up. You say it allows for 3 distinct activities: inspection, diagnostic sampling, and therapeutic intervention.
Inspection, diagnosis, therapy. Got it. Simple structure. Now, what about EBUS? That's endobronchial ultrasound. That seems to be the buzzword in all the recent papers and exams.
It is, and for good reason. EBUS is a technique that combines bronchoscopy with ultrasound imaging. Now, why does an examiner care about this?
Okay.
Because standard bronchoscopy only sees the inside surface of the airway, the mucosal layer.
Right, the lining.
Exactly. EBUS lets you visualize structures adjacent to the bronchial wall. We're not just looking at the tunnel anymore. We are literally looking through the wall at parabronchial lesions and, this is the most important part, mediastinal lymph nodes.
So if I were to put it simply, regular bronchoscopy sees the tunnel, but EBUS sees what's buried in the dirt outside the tunnel.
That is a very fair analogy. Yeah. And for exam relevance, you have to nail the why. Bronchoscopy identifies endobronchial abnormalities, tumors, foreign bodies, bleeding sites.
Right.
EBUS is now the gold standard for staging lung cancer. It allows for transbronchial needle aspiration TBNA of those mediastinal nodes without having to cut the patient open for a mediastinoscopy. It's a huge deal.
Okay, that makes perfect sense. And that brings us to the concept you called the crucial concept, the shared airway. Why is this the biggest hurdle?
Because it represents a fundamental physiological conflict. It's a turf war.
A turf war, okay.
As the anesthesiologist, your job is to use the airway to keep the patient alive by delivering oxygen and removing CO2.
Right. My one job.
Your one job. Meanwhile, the pulmonologist or the surgeon needs that exact same airway to do their job, to pass a scope, take a biopsy, remove a foreign body. You are competing for the same anatomical real estate.
Competition for the airway.
Use that exact phrase. In an exam, if you say, this procedure necessitates absolute coordination due to the inherent competition for the airway, you have already scored points. The bronchoscope itself is an obstruction. It increases resistance to airflow. It's a physiological stress test you're imposing on the patient.
Okay, so before we really get into the weeds of how we manage that, What are the common question patterns we need to be ready for? What's going to be on the test?
In the Gujarat University or DNB pattern, you'll see short notes. Things like anesthetic management of rigid bronchoscopy or jet ventilation.
The classic 5 markers.
Exactly, your bread and butter questions. Then for the long 10 to 15 mark answers, you have to expect a clinical scenario. The absolute classic is, describe the anesthetic challenges and management of a child with a foreign body in the bronchus.
Oh, yeah. We definitely need to role play that one later.
We will. And then in the Viva, it's hands-on. They'll hand you a scope, ask you to identify it. Is this rigid or flexible? Or they'll hit you with a crisis. The SATs are dropping. The patient is spasming. What do you do right now? You need to have that algorithm ready to go.
Okay. Let's move to part B then. Bronchoscopy. You've marked this as absolutely essential.
It is.
We have 2 main players here, flexible and rigid.
Yeah.
I admit, I sometimes get confused about when exactly we use which, aside from the obvious fact that one is stiff. How do I differentiate them for the examiner?
You differentiate them based on 3 things: structure, utility, and the anesthetic requirement.
Okay.
So flexible fiber optic bronchoscopy, it's pliable, it's maneuverable, it has a much smaller diameter. The key exam differentiator is that it can often be done under topical anesthesia or just light sedation.
Right. The patient can be awake-ish.
Exactly. And you use it for diagnosis and for reaching the distal airways, the really small bronchi where a big metal tube just can't go.
And the rigid bronchoscope.
Think of it as a weapon, seriously. It's a hollow, straight metal tube. It's non-yielding. Morgan's textbook is crystal clear on this. Rigid bronchoscopy is traditionally the technique of choice for 3 main things.
Okay, what are they?
Tracheal obstruction, massive hemoptysis, and foreign body removal.
Foreign bodies, bleeding, obstruction, rigid.
Correct. And the exam differentiator for the rigid scope is that it almost always requires general anesthesia, GA, and usually with muscle relaxation. You cannot shove a wide metal pipe down a conscious person's throat. It's just not going to happen.
Okay, so to summarize it for an examiner, I'd say, flexible is for diagnosis, distal reach, and patient comfort. Rigid is for intervention, proximal control, foreign bodies, and massive bleeding.
That is a perfect summary. Nail that, and you're golden on that question.
Let's talk indications in Section 3. We've listed a few, but let's be thorough. If I have to list out diagnostic indications, what am I saying?
So you're drawing from your sources, like Kaushik Jathanath's notes or the Oxford Handbook. Your diagnostic list is about investigating symptoms. Things like an unexplained cough, hemoptysis, a new wheeze, or stridor.
Okay, the common stuff.
The common stuff.
Yeah.
Then there's suspected neoplasms. You're hunting for cancer. Collection of microbiological specimens, that's your BAL, the bronchoalveolar lavage for infections.
Right.
And don't forget, assessment of the vocal cords for palsies. You see this a lot before a big thyroid surgery or after a prolonged intubation.
Okay. And therapeutic. This feels like where the real high-stakes anesthesia work happens.
It is. This is where it gets serious. Foreign
Yeah.
body removal is the big one, especially in pediatrics.
The peanut and the bronchus.
The peanut, the Lego, you name it. Then, removal of tenacious secretions or mucus plugs, often in ICU patients who just can't clear their own chest.
Mm-hmm.
Laser resection of tumors to open up the airway, which is incredibly high risk for an airway fire.
Oh, wow.
Tracheal dilation for stenosis, and stent placement to keep a collapsed airway open.
So from my perspective as the anesthetist, how do I group these in my head?
You group them by risk. It's risk stratification. Diagnostic usually implies a shorter, less stimulating procedure where sedation might be enough.
Okay.
Therapeutic, like digging out a foreign body or lasering a tumor, implies a high risk of obstruction, of losing the airway, and it almost always mandates general anesthesia to ensure the patient is perfectly still while there are sharp instruments or lasers in their lungs.
Right, that makes total sense. Okay, let's get into the physiology in Section 4. You called this exam gold. So what has actually happened to the patient's body when we stick a scope down their airway?
It's a cascade of bad things for gas exchange. It really is. First, the shared airway problem we talked about effectively means obstruction. The scope itself reduces the cross-sectional area of the airway.
Right.
And you have to remember Poiseuille's law. Resistance is inversely proportional to the radius to the 4th power. A small decrease in radius leads to a huge increase in resistance.
It's like trying to breathe through a coffee stirrer while you're running.
Exactly. And that leads directly to the second major challenge, hypoxia.
Okay.
You get hypoventilation because of that insane resistance. You get VQ mismatch because of atelectasis. Parts of the lung just collapse. And don't forget suctioning. This is a key point for exams.
What about suctioning?
When the surgeon or the pulmonologist suctions blood or mucus, they are also suctioning away your oxygen and your lung volume. They are actively de-recruiting the lungs.
That's a great point. They're literally vacuuming the air out of the patient's lungs.
They are. And thirdly, hypercapnia. The CO2 builds up because of that hypoventilation or because of periods of apnea, especially during rigid bronchoscopy where you might have to stop ventilating completely for a minute to let them work.
And what about the body's own reaction, the reflexes?
Oh, the airway irritation is profound. The airway is one of the most sensitive parts of the body. Any instrumentation causes an intense sympathetic stimulation, tachycardia, hypertension.
Right, the fight or flight response.
A massive one. And it triggers protective reflexes. Coughing, laryngospasm, bronchospasm. If you are doing this procedure and your anesthesia is too light, the vocal cords will slam shut. And then you're in real trouble.
So the anesthetic goal is this balancing act. We have to blunt those reflexes so they don't cough or spasm, but we have to keep them breathing or ventilated enough to stop them from turning blue.
You have just perfectly described the art of bronchoscopy anesthesia. You are walking a tightrope between too light, where they spasm and fight you, and too deep, where they stop breathing entirely and their blood pressure crashes. That's the challenge.
That segues perfectly into Part C, anesthetic management.
Yeah.
This is the real meat of the answer, right?
Absolutely.
So before we even induce, we need to assess the patient. Section 5, preoperative assessment. What are we looking for that's specific to this procedure?
So your standard airway evaluation is a given. Malampati, neck movement, thyromental distance, all of that. But Miller's textbook really emphasizes that you must look for specific pathology related to the procedure. Is there stridor? If a patient has stridor at rest, their airway is already critical. You have to be incredibly careful. Is the trachea deviated on the chest x-ray?
And you have to look at the scans.
You must look at the CT scan. Is there a big mediastinal mass compressing the airway? Is it an extrinsic compression?
Because if there is extrinsic compression and we paralyze them,
the airway might collapse completely. It's called dynamic airway collapse. The muscles holding the airway open relax, the positive pressure in the chest is lost, and the mass just crushes the trachea flat.
That's a cannot intubate, cannot ventilate nightmare.
The ultimate nightmare. So you have to know the nature of the obstruction before you start. Is it fixed or is it dynamic?
Okay, so beyond the anatomy of the airway, what about the lungs themselves? The parenchyma.
Respiratory reserve is absolutely key. Many of these patients have underlying COPD or asthma.
Right.
The sources, like the perioperative asthma guidelines, emphasize optimization. You want them on their bronchodilators. You want them to have had their steroids, methylmridazolone or hydrocortisone on board if they're reactive.
What about smoking?
And smoking cessation. Though, practically for an urgent scope, you're almost never going to get the 4 to 8 weeks lead time that's required for real meaningful benefit. But you should mention it.
And other comorbidities?
Cardiac status is huge. Remember that massive sympathetic surge I mentioned?
Yeah, the tachycardia and hypertension.
If your patient has ischemic heart disease, that tachycardia and hypertension during the scoping can cause a myocardial infarction right there on the table. You need to identify patients who cannot tolerate that stress or who can't tolerate the inevitable periods of apnea or hypoventilation.
Okay, now for the big decision, the one that seems to trip people up. Section 6, choice of anesthesia. Is it topical with sedation or is it general anesthesia? How do I make this decision for the examiner?
You frame it as a risk-benefit analysis based on the patient, the procedure, and the operator. Topical anesthesia with sedation is primarily for diagnostic flexible bronchoscopy in a cooperative patient. You use a spray-as-you-go technique with lidocaine, or you nebulize it beforehand. The beauty of this is that it preserves spontaneous respiration, which is inherently safer if the airway is already precarious.
And GA, when is that the answer?
GA is mandatory for rigid bronchoscopy. Full stop.
No exception.
No exceptions. It's also the standard of care for pediatric patients. They will not cooperate. Uncooperative adults. Any complex therapeutic procedure like stenting or laser, and usually for lengthy EBUS procedures.
I see Kaushik Jathanath's notes list advantages and disadvantages. What's the headline there?
For GA, the advantage is you have a totally controlled airway. You have immobility. You have complete control over oxygenation and ventilation.
And the downside?
The disadvantages are the hemodynamic fluctuations from the drugs and a longer recovery time. Sedation, on the other hand, keeps them breathing on their own. But if they cough or move at the wrong time, the surgeon can't work, or worse, perforates the airway.
So if the examiner puts me on the spot and asks, when do I say GA is mandatory?
You give them a firm, clear list. Foreign body removal, all pediatric patients, massive hemoptysis, and all rigid bronchoscopy. Do not waver on those 4.
Okay, got it. Let's talk about the plumbing. Section 7, airway management techniques. We've got a few options here.
We do. For flexible bronchoscopy, you can go nasal or oral. The nasal route is quite common for awake fiber optic procedures.
Right.
But you must tell the examiner you'll use vasoconstrictors first. Something like phenylephrine or xylometazoline spray in the nose. You have to prevent epistaxis. A nosebleed ruins the view before you even start the procedure.
That's a great practical point. What about the LMA? I've seen that used a lot.
The LMA is a fantastic tool for this. Miller's describes it as a conduit. It's a brilliant description.
What? How do it?
You place the LMA, the patient is breathing through it, and you simply pass the flexible scope through the LMA's channel. It's much wider than an endotracheal tube of a similar size, so there's less resistance to breathing around the stope.
And you can see the cords better.
Exactly. It sits above the vocal cords, so you can visualize all the subglottic structures perfectly, and it's excellent for maintaining spontaneous respiration while keeping the upper airway patent.
Okay. And for rigid bronchoscopy, what's the airway there?
For rigid bronchoscopy, the scope is the airway.
No.
That metal tube becomes your endotracheal tube. You attach your ventilation circuit to a special side port on the scope. But, and this is a huge but, when the surgeon opens the back of the scope to insert forceps or a suction catheter,
The circuit is open to the room.
the whole circuit is open. You lose all your pressure, all your tidal volume. It just vents out.
So you're only really ventilating when they close that little back window.
Correct. It's an intermittent ventilation technique. You're constantly communicating. Ventilating, ventilating. Okay, they're opening. Suctioning. Okay, they're closed. Ventilating again.
Wow.
Or
Right.
use jet ventilation. But we'll get to that.
Okay, let's talk drugs. Section 8, sedation and drug considerations. What's our ideal cocktail?
The goals are simple. You want anxiolysis, amnesia, and profound cough suppression. And you need to maintain hemodynamic stability.
Right.
So benzodiazepines like midazolam are standard for anxiolysis, maybe 0.05 to 0.15 milligeacruises. For opioids, fentanyl is very common, but remifentanil is the real superstar here, especially for the exam.
Okay, why remifentanil? I know it's expensive, but why is it the preferred exam answer?
Because of its unique pharmacokinetics, it has a very, very short, context-sensitive half-life. It's not metabolized by the liver or kidneys. It's broken down by plasma esteroses all over the body.
So it's gone almost instantly.
Almost instantly. You can run a high-dose infusion to completely knock out the cough reflex during the most stimulating parts of the procedure, and then you turn it off, and the patient is waking up and breathing spontaneously within minutes. For a stimulating procedure like rigid bronchoscopy, where you need a rapid wake-up to check airway reflexes, it is absolutely ideal.
What about propofol?
Propofol is your workhorse. It's standard for induction and maintenance, usually as a TIVA, a total intravenous anesthesia infusion.
Why Tiva over an inhalational gas?
Because the circuit is open to the room so often, right? If you were using sevoflurane, most of it would just leak out, polluting the OR and not keeping the patient asleep. T-Fly gives you consistent depth, regardless of circuit leaks.
And I see dexmedetomidine mentioned in the Yao and Artuzio source.
Yeah.
Where does that fit in?
Dexmedetomidine is a great choice for what's called cooperative sedation. It provides sedation and some analgesia without causing significant respiratory depression. It's great if you want the patient awake enough to follow commands, but comfortable and not coughing.
And one last thing. Don't forget the antisialagogue.
You must not forget it. Glycopyrrolate is your friend. You have to dry up the secretions. If the lens of the scope is constantly being covered by mucus, the procedure fails. A dry airway is a happy airway for the bronchoscopist.
Right. Moving to section 9, oxygenation and ventilation strategies. We've touched on the side port ventilation for the rigid scope, but what is this concept of apneic oxygenation?
Morgan explains this very well. It's a fascinating physiological principle. It relies on the mass movement of oxygen from the alveoli into the blood.
Okay.
So you insufflate oxygen, usually via a small catheter, deep into the airway. Even if the patient isn't taking a breath, if they're apneic, the oxygen in their lungs is still being rapidly absorbed into the bloodstream. This creates a pressure gradient, a sort of vacuum, a subatmospheric pressure in the alveoli that literally pulls more oxygen down the trachea from your source.
So you're getting oxygenation, but the CO2 doesn't leave.
That's the catch, exactly. You get oxygenation without ventilation. The CO2 has no way out, so it accumulates, leading to a progressive respiratory acidosis. You're limited by time, usually only 10 to 20 minutes before the patient's pH drops dangerously low.
Got it. And now for the big buzzword, jet ventilation.
Ah, yes. Jet ventilation uses something called a Sanders injector. It's a device that shoots a high-pressure jet of pure oxygen down the scope.
So you're just blasting oxygen in.
You are. And as that high-pressure jet shoots forward, it entrains room air from the side port. That's the Venturi effect, which increases the total volume delivered to the patient.
What's the danger? It sounds risky.
The danger is barotrauma. Massive barotrauma. You are blasting high pressure into the lungs. If that air has no way to get out, let's say because of a ball valve obstruction from a tumor, or the scope is wedged too tightly in the trachea, you will blow a pneumothorax or a pneumomediastinum. It's a catastrophic complication.
So what is the absolute #1 rule?
Rule number 1 of jet ventilation: always ensure an egress path for the gas. If air goes in, air must be able to come out.
Always ensure an egress path. Yeah, I'm tattooing that on my brain.
Yeah.
Let's shift gears now to Part D, endobronchial ultrasound, or EBUS. This seems to be more and more common in exams.
It's essential now. It's largely replacing surgical mediastinoscopy, so you have to know it.
Okay, Section 10, principles and types. What is it, fundamentally?
Fundamentally, EBUS involves an ultrasound probe that's been incorporated into the tip of a flexible bronchoscope. It allows us to, as we said, see through the bronchial wall.
And there are 2 types, radial and convex.
That's right. The radial probe gives you a 360-degree view, which is good for looking at peripheral lesions or small pulmonary nodules. But the convex probe is the one we use most for staging. It gives a linear view, which is what allows for the needle aspiration, the TBNA. You can see the needle in real time on the ultrasound as it enters the lymph node.
So why do we, as anesthetists, care so much? Isn't it just another bronchoscopy from our end?
No, it's very different. It's a hybrid procedure with a unique set of challenges. It has the invasiveness and risk of a deep biopsy, combined with the significant airway obstruction of a large scope.
So Section 11, indications. You said it's mainly for cancer staging?
Primarily. The #1 indication is staging of non-small cell lung cancer. They're looking for spread of cancer to the mediastinal lymph nodes. If those nodes are positive, the patient might not be a candidate for surgical resection. The result of this one test can determine the patient's entire treatment plan. It's a high-stakes procedure.
Okay, this is why Section 12 calls it exam gold. What are the specific anesthetic challenges in EBUS that are different from a regular scope?
Okay, first, duration. An EBS procedure is generally much longer than a quick look-see bronchoscopy. They have to systematically map out all the lymph node stations and then carefully sample each one.
So more time under anesthesia, more risk.
Exactly. Second, the scope size. EBUS scopes are bulkier. They're almost 7 millimeters in diameter. If you put that scope through a standard size 7.5 or 8.0 endotracheal tube, you are blocking a huge percentage of the lumen. Airway resistance goes right through the roof.
And someone mentioned a balloon.
Right. This is critical. To get a good ultrasound image, the operator has to inflate a small saline-filled balloon at the tip of the scope, pressing it against the airway wall.
So that creates a complete obstruction of that bronchus while they're scanning.
A complete 100% obstruction. So if they are in the right main bronchus and they inflate that balloon, you are now effectively doing one lung ventilation.
Wow. But without a double lumen tube or a bronchial blocker.
Precisely. So if the patient has poor respiratory reserve to begin with, they will desaturate instantly.
And the kicker, I'm guessing, is immobility.
That's the absolute kicker. The pulmonologist is passing a sharp needle through the bronchial wall into a lymph node that is often sitting right next to the pulmonary artery, or the aorta. If the patient coughs or moves at that exact moment,
That's a disaster. You puncture a major vessel.
it's a catastrophe. A massive bleed in the mediastinum. So while you can
Right.
technically do these procedures under deep sedation for exams and often in real-world practice for safety, general anesthesia is strongly preferred. You need that absolute guarantee of immobility.
Okay, so that leads to Section 13, techniques for EBUS. If GA is the way to go, what's the airway device of choice?
This is a great discussion point for an exam. Miller's actually suggests that an LMA can be a better choice here.
An LMA, why not a definitive ETT?
Because the LMA, a supraglottic airway, sits above the glottis. This allows you to pass the large EBUS scope through the vocal cords, and you still have the entire tracheal lumen to ventilate around the scope. It can offer lower resistance than trying to cram that big scope down a relatively narrow endotracheal tube.
I see. but I imagine some people still prefer an ECT.
Oh, absolutely. Many anesthetists prefer a large bore endotracheal tube like a size 8.5 or even a 9.0 to ensure a definitive, secured airway, especially if there's a high risk of bleeding. Both are valid options, and you should be able to discuss the pros and cons of each.
Okay, that's a key point. Let's move to Part E, complications and safety. This is another really high-yield area. Section 14, what can go wrong?
The most common thing to go wrong by far is hypoxia. Desaturation due to all the reasons we've already discussed, obstruction, suctioning, VQ mismatch,
After that,
bronchospasm, and laryngospasm, especially if the anesthesia is too light for the degree of stimulation.
what about bleeding?
Bleeding is a major concern, especially after a biopsy or a TBNA. Miller's notes that it's usually self-limiting, just a bit of oozing, but it can be massive and life-threatening.
And pneumothorax.
That's a real risk with any transbronchial biopsy. If the needle goes too far, it punctures the pleura and the lung collapses. Or, of course, barotrauma from jet ventilation.
And arrhythmias.
Very common, usually due to that huge sympathetic surge or from hypoxia. You can also get profound bradycardia if there's strong vagal stimulation deep in the airway.
Okay, Section 15, management of complications. Let's do this rapid-fire Viva style. I'm in the middle of the case. The pulse oximeter alarm is going off. Sats are dropping to 85. What is the first thing I do?
You stop everything. You tell the operator, stop the procedure. Then you ask them to withdraw the scope to the mid-trachea or, if necessary, remove it entirely.
Get the obstruction out?
Get the obstruction out. Then you administer 100% oxygen. And you gently assist ventilation with the bag. You cannot ventilate effectively with that huge scope still blocking the airway.
Okay, new scenario. They just took a biopsy, and now there's bright red blood filling the airway, bleeding.
First, suction. Then you can instill cold saline through the scope to cause vasoconstriction. You can also give topical epinephrine solution, a 1 in 10,000 or 1 in 20,000 solution down the scope.
And if it's massive?
If it's massive, the operator can wedge the tip of the bronchoscope into the bleeding bronchus to tamponate it. This also protects the healthy lung from being flooded with blood. And you should immediately turn the patient so the bleeding side is down.
All right, good lung up.
Yeah.
Okay, last one. I hear a wheeze and I can't ventilate. Bronchospasm.
First, deepen the anesthesia, increase your propofol or your volatile agent. Sevoflurane is a potent bronchodilator. At the same time, give bronchodilators salbutamol puffs right into the circuit.
So if the examiner asks me, what is your primary safety rule during any of these complications?
Your answer is safety first. I would immediately stop the procedure, withdraw the scope, and secure the airway and ventilation. You never try to fix the problem through the disaster while the scope is still obstructing everything.
Okay. Part F, post-procedure care. Section 16, monitoring, the procedure's done, the patient is waking up. What are we watching for like a hawk?
You're watching for the return of their airway reflexes. They absolutely must have them back before discharge to prevent aspiration, especially if you used a lot of topical anesthesia on their vocal cords. They need to be able to protect their own airway.
What about hemodynamics?
You're watching for any delayed bleeding, which can manifest as tachycardia or hypotension.
And oxygenation?
You have to watch for a delayed pneumothorax. It doesn't always show up immediately. If they did a biopsy, a post-procedure chest x-ray is often very prudent. At the very least, you need close observation for any signs of respiratory distress, desaturation, or subcutaneous emphysema.
Section 17. What are the discharge criteria? When is it safe for them to go home?
You use the standard PADS, the post-anesthetic discharge scoring system. They have to be awake, alert, with stable vitals. But specifically for an airway procedure exam answer, you add 3 more things.
Okay.
Ensure no stridor, ensure no active hemoptysis, and ensure they have the ability to swallow water without coughing or choking.
Perfect. All right, Part G. This is where we bring it all together for the exam. Section 18. Flexible versus rigid bronchoscopy. This is a classic comparison. Let's build that mental table for the examiner.
Let's do it. It's all about direct comparison.
Indication. Flexible is for diagnosis and looking at peripheral lesions. Rigid is for foreign bodies, massive bleeds, and central obstructions.
Got it. Row 2, anesthetic.
Flexible usually uses sedation. Rigid always uses GA.
Row 3, ventilation.
Flexible, you're looking at spontaneous breathing or ventilation via an LMA. For rigid, it's either the sidearm port or jet ventilation.
And finally, complications.
Flexible has a much lower risk of airway trauma. Rigid has a higher risk of dental damage, lip injury, and laryngeal trauma from insertion.
Okay, that's clear. Now, Section 19, bronchoscopy versus EBUS. How do we compare those?
EBS is a specific high-tech subset of flexible bronchoscopy. The purpose is different. Staging for EBUS versus general diagnosis or therapy for standard bronchoscopy.
And the airway management reflects that.
It does. EBS leans very heavily towards general anesthesia with an LMA or a large ETT. Why? Because you need that absolute immobility and you have to manage the airway obstruction from the larger scope. A standard flexible bronchoscopy, on the other hand, leans much more towards sedation.
Perfect. Section 20. Common exam questions and Viva traps. We mentioned the foreign body child. Let's really role play this. The examiner asked me, I have a 3-year-old who has inhaled a peanut. It's in the right main bronchus. How do you induce anesthesia?
This is the ultimate trap. Do not say rapid sequence induction. Do not say, I would paralyze the child. You will fail on the spot.
So what's the right answer?
The correct, safe answer is inhalational induction with sevoflurane, maintaining spontaneous ventilation.
Why is paralysis so incredibly dangerous here?
Because the negative pressure generated by spontaneous breathing actually helps to keep the airway open around the foreign body. If you paralyze them, all the airway muscles relax, the mediastinum can shift, and that peanut might dislodge and move, turning a partial obstruction into a complete can't ventilate obstruction.
Right.
You maintain spontaneous ventilation until the surgeon has the rigid scope in and has visually secured the foreign body with forceps. Only then, once the airway is physically controlled, can you consider giving a muscle relaxant if needed.
Okay, that's a critical point. Trap number 2. Can you do rigid bronchoscopy under sedation?
The answer is an emphatic no. It requires general anesthesia and, in most cases, muscle relaxation to allow the passage of that large metal tube past the vocal cords without causing trauma. The only nuance is in some complex tracheal stenosis cases where you might preserve spontaneous ventilation, but that is still a form of GA, not just sedation.
And the third trap, we've mentioned it, but let's hit it one more time. Jet ventilation.
The mistake is forgetting the egress, forgetting the outflow. If you describe jet ventilating into a closed system, you are describing a fatal barotrauma. It is an automatic fail.
Okay. Session 21. Diagrams and exam presentation. If I have to draw the bronchoscopy airway setup for a 10-mark answer, what does that look like?
Keep it simple but clear. Draw the patient supine. Draw the anesthesia machine on the left or right, but make a note that you need a long circuit, an extension tubing, because the anesthesiologist is often displaced to the side to give the surgeon room at the head of the bed.
Right, the surgeon is at the head.
The surgeon is at the head. Draw the oxygen source for your jet ventilation as a separate high-pressure line, and show the monitors, ECG, SATS probe, BP cuff, and make sure they're positioned to be visible to both you and the surgeon.
What about a cannot ventilate flowchart?
Very high yield. Box number 1, call for help. Box 2, ask surgeon to withdraw the scope immediately. Box 3, attempt mask ventilation with 100% O2. If that fails, box 4, insert LMA. If that fails, box 5, intubate, preferably with a video laryngoscope. And if that fails,
Cannot intubate, cannot ventilate.
you go to your surgical airway algorithm, scalpel bougie tube, a cricothyroidotomy. You have to show you have a plan for failure.
Okay. Finally, section 22. Summary and exam conclusion. Can you give me the elevator pitch for the exam, the final take-home message?
Okay, here are the absolute key points.
Bronchoscopy is a shared airway procedure requiring absolute constant communication.
Hypoxia and arrhythmias are your primary enemies. You must anticipate them.
Right.
3, choose GA for rigid, therapeutic, or uncooperative cases.
Choose topical with sedation for cooperative, diagnostic, flexible cases.
EBUS requires immobility, so you should lean towards GA with an LMA or a large ETT.
Never forget the egress rule for jet ventilation.
And number 7,
Communication with the pulmonologist or surgeon is the most important monitoring tool you have.
communication with the pulmonologist is the most important monitoring tool. I love that. That's the perfect concluding line.
It saves lives. It really does. If they are about to take a biopsy, they need to tell you so you can ensure the patient is deep and doesn't move. If you are losing the airway, you need to tell them clearly and loudly to get out.
This has been incredibly high yield. I actually feel like I can structure that 15-mark question now.
Just remember the structure we talked about. Definition, indications, physiology, anesthetic management, and complications. Stick to that framework and you will pass.
Thank you so much for this. To our learner listening, visualize that shared airway setup before you walk into the exam hall. Keep your airway clear and your answers even clearer.
Good luck.
See you next time on The Deep Dive.